As a part of CPB Simplified Series, in this video, we are going to see about antegrade cerebral perfusion and retrograde cerebral perfusion. At normothermia, the total cardiac output is distributed to all the vital organs of our body as shown in this picture. Here you can see the brain requires 15% of cardiac output generated by the body to meet the metabolic demands. The brain is 2% of our body weight. It consumes 20% of our total oxygen consumption of our body. It utilizes 25% of total body glucose. It has no glucose stores. It requires constant blood flow to meet the metabolic demand. Even when we are cooling down the patient to the 16 degrees centigrade, the cerebral metabolic rate of oxygen demand remains at 15%. There is always a possibility of neurological injury even during HCA because of this CMRO2 demand. So, to give extra protection to the brain and to prolong the safe duration of the circulatory arrest, we can either use antegrade cerebral perfusion or retrograde cerebral perfusion. Let us see about antegrade cerebral perfusion. Antegrade cerebral perfusion is a technique which uses special cannulation procedures to perfuse only the brain and provide optimal cerebral protection during hypothermic circulatory arrest. Antegrade perfusion of the brain through cannulas inserted in the branch vessels of aortic arch, which provides the most physiologic and efficient perfusion of the brain. The advantages of ACP are it has the better ability to match the demands of brain metabolism, better control of brain temperature, and it prolongs the safe duration of HCA than retrograde cerebral perfusion. It has homogeneous brain cooling methodology. It is more reliable than retrograde cerebral perfusion for global oxygenation. The disadvantages of antegrade cerebral perfusion are malperfusion could manifest due to the prolonged arch vessels hyperperfusion. When we have an incomplete circle of Willis while performing UACP, risk of arterial wall dissection, risk of embolization, risk of cannula displacing or kinking, which results in decreased oxygen supply, and it needs intact circle of Willis if unilateral perfusion is used. It can cause injury from excessive perfusion pressure to the brain. There are two types of antegrade cerebral perfusion. One is unilateral antegrade cerebral perfusion, another one is bilateral cerebral perfusion. If the patient is having complete circle of Willis, unilateral antegrade cerebral perfusion can be used. It can be performed by cannulating one of the aortic arch branch vessel. If the patient is having incomplete circle of Willis, it's better to use bilateral antegrade cerebral perfusion for optimal cerebral protection. It can be performed by cannulating 2 or 3 branch vessels of the aortic arch. In this diagram, you can see the branches of arch of aorta which supplies blood to the brain. The branches are brachiocephalic artery, left common carotid artery, and left subclavian artery. Let us see about circle of Willis. The circle of Willis is the joining area of several arteries at the inferior side of the brain. At the circle of Willis, the internal carotid arteries branches into small arteries that supply oxygenated blood to over 80% of the cerebrum. The circle of Willis also allows blood to flow across the midline of the brain if an artery on one side is occluded. The circle of Willis thereby serves as a safety valve function for the brain, allowing collateral circulation to take place if the flow is reduced to one area. Among the population, 15 to 20% to as high as 47% of people have incomplete circle of Willis. So, circle of Willis plays an important role in deciding whether to employ unilateral or bilateral antegrade cerebral perfusion to protect both left and right side of the brain. In these diagrams, we can see the complete circle of Willis and incomplete circle of Willis. It can be diagnosed using magnetic resonance angiography or transcranial Doppler sonography to find whether the patient is having complete or incomplete circle of Willis. Let us see about the cannulation sites required for unilateral cerebral perfusion. Innominate or brachiocephalic artery, right subclavian artery, axillary artery, right brachial artery. While delivering unilateral antegrade cerebral perfusion, make sure innominate artery, left common carotid artery, and left subclavian artery are occluded to avoid stealing of blood into the aorta. The cannulation sites for performing bilateral antegrade cerebral perfusion are axillary artery through graft and the left common carotid artery with a balloon occlusion cannula. Bicarotid perfusion with the two balloon occlusion cannulas. Axillary artery, left common carotid artery and left subclavian artery. Axillary artery and left subclavian artery. Now let us see about how to conduct antegrade cerebral perfusion. The perfusion temperature should be kept around 15 degrees centigrade to 18 degrees centigrade. The flow should be maintained between 10 to 20 ml per kg per minute. The hematocrit should be around 21% to 30%. We have to monitor right radial artery pressure and it should be around 40 to 50 mmHg. Antegrade cerebral perfusion in the occlusion of arch vessels will ensure the perfusion of circle of Willis. When we are giving unilateral antegrade cerebral perfusion, we should avoid hyperglycemia. We should keep the ABG values normal. It's better to consider pH stat management. Leave the venous line unclamped to the reservoir to get back the returns while giving ACP. In this circuit, venous drainage is obtained from RA or SCC-IVC or femoral vein cannulation. It is drained into the venous reservoir and from the reservoir through the pump, the blood is oxygenated using the oxygenator. While delivering unilateral antegrade cerebral perfusion, make sure to clamp the femoral artery line from the bifurcation and flow through the axillary artery line. Ensure proximal clamping of arch vessels to avoid stealing of blood into the aorta. Keep an Y in the arterial line to facilitate antegrade cerebral perfusion delivery through axillary artery and left common carotid artery as shown in this diagram. You can occlude the proximal innominate artery with a snare during the delivery. This circuit shows how to deliver your bilateral antegrade cerebral perfusion using innominate artery and left common carotid artery. This circuit ensures bilateral antegrade cerebral perfusion with the use of a circuit which has a trifurcation to facilitate ACP delivery through innominate artery, left common carotid artery and left subclavian artery through separate balloon perfusion catheters. Now let us see about retrograde cerebral perfusion. Retrograde cerebral perfusion is a technique which uses SVC cannula to perfuse only the brain retrogradely to prolong the safe duration of the circulatory arrest and provide optimal cerebral protection during HCA. This technique uses a standard CPB circuit without need of any extra cannulation or instrumentation of the aortic arch vessels. During delivery of retrograde cerebral perfusion, the superior vena cava cannula is snared between the right atrium and the azygos vein. The advantages of retrograde cerebral perfusion are: it provides cerebral metabolites. It helps to prolong safe duration of HCA to 45 to 60 minutes. It maintains cerebral cooling. It retrogradely flushes out air and debris and blood cell microaggregates from the cerebral vessels. It is also used as an adjunctive therapy for the management and treatment of cerebral embolic events. We can see about disadvantages of retrograde cerebral perfusion. In RCP delivery, a significant degree of shunting occurs between the superficial and deep cerebral veins, leading to limited delivery of oxygenated blood to the cerebral artery. Cerebral edema may occur if we maintain pressure greater than 25 mmHg. It can increase the intracranial pressure, and low level of substrate supply will be happening during RCP. How to conduct retrograde cerebral perfusion? The perfusion temperature is usually set at 15 degrees centigrade to 18 degrees centigrade. The flow should be maintained between 200 to 500 ml per minute. The CVP should be maintained below 25 mmHg. Avoid hyperglycemia. Keep the ABG values normal, and the blood will be returned back to the pump using cardiotomy suction. The return blood can be monitored through the opening aortic arch through the branch vessels. Now let us see about the circuit required for cerebral perfusion retrogradely. As shown in this diagram, the design of the circuit includes a shunt line between arterial and venous line. And while giving RCP, after achieving the desired temperature of 16 to 18 degrees centigrade, clamp the arterial line, clamp the venous line to the reservoir, and clamp the IVC line after the bifurcation Y of venous line. Now, open the shunt line and open SVC line to deliver retrograde cerebral perfusion. This is the most commonly used circuit for RCP delivery all around the world. In some centers, instead of having a shunt line, they will disconnect both arterial line and SVC line from the cannula and reconnect the arterial line to the SVC cannula to deliver retrograde cerebral perfusion during HCA. Transcranial Doppler sonography, near infrared spectroscopy, jugular venous oxygen saturation, electroencephalography, somatosensory evoked potential monitoring are used as the neurological monitoring during HCA with ACP and RCP. Most commonly, NIRS and TCD are used for cerebral physiological monitoring for cerebral blood flow velocity and regional oxygen saturation. During TCA, bilateral NIRS monitoring is required, and we should maintain bilateral regional oxygen saturation of about 90 to 95%. If the left side regional oxygen saturation is going below the right side regional oxygen saturation, that is, RSO2 of left side is below 80 to 85%, increase the blood flow rate and increase the hematocrit to bring up the RSO2 of the left side. Transcranial Doppler is used for real-time cerebral blood flow velocity monitoring in the basal arteries of the brain. During ACP, the left side of the brain may develop significantly lower regional oxygen saturation than the right side. This occurs because all the flows through the left side during ACP must occur via the circle of Willis, and because of patients having incomplete circle of Willis will have RSO2 of 30% lesser than the right side. So, bilateral cannulation is preferred in patients with incomplete circle of Willis. Here, TCD is used to guide antegrade cerebral perfusion flow rates and cerebral blood flow velocity during HCA. The goal is to maintain mean cerebral blood flow velocity of 18 to 25 cm per second. Hope this video helps you to understand about ACP and RCP during HCA. Stay tuned for more videos in the CPB Simplified series. Subscribe my channel to get notifications for new videos. Thank you.